So my talk will cover the following: an overview of this MicroPulse scleral laser therapy, patient selection, surgical guide, pre-op, post-op retreatment, and the treatment technique. So when you're using a diode laser, especially applied transsclerally to target the ciliary body, there are two modes that you can use to deliver the laser. And one is through a continuous wave, strong energy pulse that is directed to the pars plicata. This is familiar to us, that the conventional method that we know of continuous wave conventional PCP. The other method is through a series of short, repetitive pulses with rest period in between that we call MicroPulse. And the laser is directed to the pars plana. And this is now the focus of our webinar, MicroPulse Transscleral Laser Therapy, or TLT. Now, with the introduction of this particular treatment for glaucoma, there are now proposed mechanisms for its possible intraocular pressure lowering. And one is the increased enhanced UV scleral outflow through enlarged extracellular spaces. And secondly, the group of Johnstone theorized that because of ciliary muscle contraction, a resulting movement of the scleral spur and trabecular meshwork causes a change in the aqueous outflow pathway shape, thus decreasing the intraocular pressure. Now, in order to deliver the energy, we need a customized probe, and this probe was invented and validated by the group of Professor Paul Chu in Singapore. So as you can see from this slide, we had the initial version to the second version, and then it evolved to the currently commercially available MicroPulse P3 device. And now that you know the probe and the mechanisms and the potential patient now that we have to select for this therapy, what should be considered? What are the factors that can affect? First is let's discuss age. Practically, the adults of any age group may benefit from the procedure. They are good candidates, but of course, because of the robust evidence in the literature, you have a lot of supporting evidence regarding its efficacy in adults. Regarding a pediatric age group, there are also surgeons who had tried using it. It may also be of benefit, but there is still not enough evidence to embark on pediatric age group. The gender factor, there's no restriction, race, no limitation, and it can also, it can be applied to all glaucoma types practically, whether it's primary, secondary, open angle, angle closure, refractory or non-refractory. But we must bear in mind that response to treatment may vary depending on the type. It is this laser therapy is useful as alternative for patients intolerant to medications and those who are medically unfit for incisional surgery, or as an adjunct for those needing additional intraocular pressure lowering with or without prior glaucoma procedures. It's also a very viable option as a temporizing measure before any incisional glaucoma surgery to prevent complications post-op. So let's move on to some preoperative surgical guides. So after a complete ophthalmologic examination, with, of course, special emphasis on a anterior chamber reaction on the pupil size, which is now some surgeons are complaining of this side effects post-treatment. So you have to take note of that. Before asking your patient to sign any informed consent, it is very important to manage their expectations and to discuss certain aspects of the treatment. And what are these aspects? The success and the failure based on glaucoma types, the intraocular pressure lowering and the number of medicines after treatment. In our center, we have been using this laser for many years, and we had gathered some data regarding its use in different types of glaucoma. So when we counsel patients for this procedure, we inform them of the experience that we had in patients that we had treated in the past, as you can see from this table. Also, it is equally important to discuss the type of anesthesia. This is a very good procedure. It's short. It can be performed in your clinic or in the office. Because of that, you can make use of local anesthesia by peribulbar or retrobulbar. And now some patients may require sedation. And currently, there is a growing interest in doing it topically. And in our center in Singapore, we started actually with local anesthesia through peribulbar, but now majority, about 60% or 70%, we can perform it under topical and with a certain cocktail of topical anesthetic. And also equally important is single treatment. Discuss with the patient whether his condition will only require single treatment or a repeat treatment. Let's move on to the treatment technique. So the laser setting is important because this will be the basis for the success, also as part of the basis of the success of your surgery. But what is an ideal parameter? Is there such a thing as an ideal laser parameter? Well, I believe it's a good balance between efficacy and sustained effects with minimal side effects and complications. For our center, what works, this particular parameter works for us for many years, and this consists of about 2000 milliwatt power. The treatment time is about 100 seconds pulse envelope, 50 seconds applied to superior and 50 seconds inferior hemispheres with 10 seconds dwell time per hemisphere. And you can also use it 5 seconds per quadrant if you would like it per quadrant. And I advise to spare the 3 and 9 o'clock meridians to avoid complicating scenarios after. So the method is continuous painting, and the duty cycle is 31.3%, which means that the laser is on for 0.5 milliseconds and it's off for 1.1 milliseconds, delivering about 62.6 joules per treatment. So you can see how the probe is applied to the sclera from the diagram, and the tip of the probe, which is very important to bear in mind, the 2 sides of the tip of the probe. I will show you later in the video, and of course, the technique. So after setting your laser parameter into the Cyclo G6 box, now you're ready to treat. So here is a short video clip. This is unedited of the technique as performed by one of our fellows. And let me just play this video. So check the orientation. So the notched side, rounded side should be towards the limbus. The flat side should be towards the lids. And then the movement is painting fashion. The dwell time, this is a good dwell time. Observe that it's about 10 seconds per sweep, okay? The angulation of the probe, it should be aiming towards the middle of the globe. And try your best now as you move to try to move your probe about 1 to 2 millimeters away from the limbus, no? And as you sweep, it's important to keep your eye lubricated. So the There should be a form of viscous gel to prevent the escape of effective laser energy. So the company has provided us with the short summary of all those factors that I had mentioned to that affects the performance of the technique. The liquid interface and is very important, as I mentioned. Probe orientation, position from the limbus. Oh, I forgot to mention the pressure into the globe. There should be adequate pressure, like a pen to paper, no? And the dwell time is important, about 4 to 5 passes per duration for both hemispheres, and power and duration. Post-operatively, you can, after the treatment, you can give your patients 1 week of topical steroids because the inflammation is not so much. So for us, 7 days of loteprednol 3 times a day is usually enough to cover the inflammation for a week. And you can also give some oral analgesics for as needed for 2 days. We don't usually stop the glaucoma drops. We are going to taper it only depending on the response of the patient in relation to the target set pre-op. And the follow-up, we usually will ask them to come back in 1 to 2 weeks, and then 4 weeks later, and then 3 months, 6 months thereafter. So in some conditions, in certain situations, the response to the first treatment may not be great. So it's suboptimal or minimal or no response at all. And we observe that some patients, especially those with neovasculars, aphakic, or secondary glaucomas, and those with advanced cases, they usually respond very minimally. And the theory that we have, we hypothesize that probably because these conditions have more of the scarring and the inflammatory debris, that's why the uveoscleral outflow are waterproof from the effect of the laser. So you can consider the option of giving a second treatment. We had provided information regarding second treatment in our publications in 2010, in 2015, and currently we also had a very good modified technique for those with suboptimal response that you can read on in the Journal of Glaucoma. It's a very recent publication. So in conclusion, while it is very easy to use this new treatment modality called MicroPulse TLT, but we must use it carefully. And it's powerful, it's efficient, and easy to use. Therefore, it's prone to misuse. As a take-home message, do this laser therapy with proper or correct technique so that you can get the best outcome from your patients. Thank you. And thank you also to the glaucoma team from the National University Hospital. Thank you.
So the following to the Cecilia's presentation, I want to introduce my slide. Okay, I want to do this. So as you know, clinical evidence more, so over 70 studies show consistently low adverse events, and also sustained IOP reduction, so around 30 to 50% in 60 or 95% of patients. And over 500 eyes in studies demonstrating durability greater than 12 months. And also, so over 2,500 eyes studied in a wide spectrum of glaucoma types and stages. So many papers indicate IOP lower. So this procedure can reduce IOP around 30%, and also topical medications, so 50%. So these papers indicate the evidence for moderate stage glaucoma, so defined as over 2 medications maximal tolerated medical therapy and pre-incisional therapy or post-incisional therapies. And these are all same papers, so indicates, and also Al-Habash so indicates, so encouraging treatment option for patients as a primary procedure in case of high IOP or medication intolerance. So around 52% IOP reduction, topical medication 20% reduction, and all patients can off oral CAI. And also there are many peer-reviewed studies around MicroPulse TLT, so including many situations as uncontrolled glaucoma patients and keratoplasty eyes, and many complicated cases. So I want to show Japanese refractory case. The subjects are consecutive 48 eyes of 46 Japanese glaucoma patients who underwent MicroPulse TLT from July 2017 to 2019. MicroPulse TLT was delivered with 2000 milliwatt for 80 seconds, 8 passes per hemisphere. So 10 seconds per passes. The duty cycle was 31.3%. The patients were given 0.1% betamethasone sodium phosphate hydrox 4 times a day for 1 week. And the IOP and medication score were measured at baseline 1, 3, 6, 12 months after treatment. So these are demographic and clinical characteristics of the patients. The age is 66, gender is 28, men and female is 18. Pseudo exploration glaucoma is 36%, secondary glaucoma is 24%, POAG is 22, neovascular is 10, and developmental glaucoma is 4%, and 1 case is of PAC-G. The baseline IOP, so before treatment, is 31.8 millimercuries, and the medication score is 4.6. So this is a result. The left side indicates the changes of IOP. The IOP go down 21.5 millimercuries at 1 month, and in 12 months, 21.0 millimercuries. The reduction rate is 29.3%. And also medication score reduced from 44.4 to 3.2. So this is the number of the millimercury and the IOP and the medication scores. The medication score reduction is 34.2%. So finally, 1 eye received trabeculotomy and 3 eyes received trabeculectomy. The procedure is only 1 MicroPulse TLT is 83%, and the additional MicroPulse TLT is 7 eyes. IOP reduction rate is 29.3, and the ratio of over 30% reduction is 56%. And the reduction of medication is 34.2%. And the complication is here, no phthisis bulbi, hypotony, and vitreous hemorrhages. And the 2 cases indicate corneal epithelial disorder, but cured within a month. And also prolonged anterior chamber inflammation in 1 case. I want to show these cases later. So this is the results of glaucoma subtypes. In exploration glaucoma, the pre-IOP is 32.3 and to 24.7 in 1 year. IP reduction rate is 28%. So among exploration glaucoma patients, 1 received trabeculotomy and 2 received trabeculectomy to get the target pressure within a year. And for secondary glaucoma, only 1 case received a trabeculectomy, but 9 cases indicate nice IOP around 22. In our cases, neovascular glaucoma, the IP reduction is less compared to the other subtypes of glaucoma, around 15%. In almost all cases, the IP reduction in total is 29%, and we can reduce the medication 34%. And also, in use of oral CAI, we can reduce them 69%, 67%. So I definitely believe, so this is very successful for our refractory cases with various subtypes. So this is my final statement. MicroPulse TLT is very effective on IOP reduction without severe complications in 1 year. So thank you very much. So thank you, everyone. So we need to move to the next. So Iresh Patel. So Iresh. So please give us a talk.
Okay, thanks very much. Good evening, everybody. It's a chilly evening here in Sydney. It's a pleasure to be with you. Thanks for the introduction. And I am enjoying the presentations this evening. While I am an experienced user of this technology, there's always something new that you can learn. So I'm going to talk about the learning curve associated with MicroPulse laser and provide some tips that I wish that I had when I was starting off with using this technology. The issue that we all face when we get going with the platform are very similar. So a typical situation is that you've seen the data on MicroPulse laser and you decide that you're happy with it and you want to offer it to your patients. Most of you will be in a situation of being established in practice and bringing this new technique to your practice. It's very different from when we're doing a fellowship and we're being trained to perform the procedure. So we have to train ourselves to do this new procedure, which has its challenges. Fortunately, the learning curve with this procedure is very straightforward. So then the issues that arise, how do we get going? What sort of patient is suitable to start with? What sort of training is required? And what do we tell the patient in terms of the efficacy and the safety and what to expect during and after the procedure? So let's go through some of these issues. Now, which cases are we going to do first? When we have established therapies to treat a condition, we are often going to do our worst cases first when it comes to trying something new. We're not going to choose a patient who is stable or a younger patient or someone who has early disease. My first 2 cases, I think, are cases that we all have in our practices. So my first case, the first case I ever did was a 92-year-old lady. She has pseudoexfoliative glaucoma. She'd been a patient of mine for many years, and as sometimes happens in pseudoexfoliation, the pressure had been cruising pretty nicely for quite a long time, and then it just shot up to 36. And despite maximal medical therapy, we could not get the pressure under control. So even though she's 92 years old, she's fit for trabeculectomy, so there were no problems with her having surgery. However, the problems that she had was with mobility and living alone. So what was really an issue for her was follow-up after surgery. She needed a family member to go to her house to pick her up and bring her to the clinic. So the frequent follow-up required after incisional surgery was going to be a problem for her. So I felt this lady was a really good candidate for my first MicroPulse TLT case. My second patient was a younger patient. He'd had multiple retinal detachments. His conjunctiva was a mess. We all know what happens when we let the retinal surgeon near the eye. He had a superior buckle, and the retinal surgeon felt that this should not be removed. His pressure on maximal treatment was 30. So we had some difficult choices to make in terms of incisional surgery. On the basis that it would do very little harm, I decided to try MicroPulse TLT. So that was my second case. Now, one of the issues that we had was that no one in my town was really doing MicroPulse TLT. So when I started, it was a real learning curve to get going. But the support from the company was very good, and they provided many resources to help. There was reading material provided and some videos. And I also had access to surgeons in other countries who were experienced users, so that was very helpful. So my first cases were done in the operating theater, which in hindsight was a very good move. The patients had a subtenon block, so we did not need to worry about their comfort. I could concentrate on getting the holding of the probe correct and applying the right amount of pressure to the sclera. I allowed adequate time to do those cases, so you don't really want to be rushing with your first cases. So I was very used to doing cyclodiode laser where you're pressing the probe on the sclera. So the sweeping motion that we use in MicroPulse TLT was quite foreign to me. So to be able to sweep across the sclera smoothly while keeping the probe perpendicular to the sclera, and at the same time, maintaining a certain amount of pressure on the sclera does take a few cases to master. So one tip that I have for everyone is to practice that sweeping motion in one quadrant of the eye before you actually engage the laser. So with your first few cases, before you actually engage the laser, do just go through that motion of sweeping across a hemisphere or a quadrant before you actually engage the laser. So have a dry run before you do the actual laser. One thing you do need to take care of is that you don't shear any blood vessels and cause a subconjunctival hemorrhage, because if you do, then it does make the delivery of the laser energy to the tissues a bit more difficult. So in terms of the procedure itself, I have a video here to show you. Dr. Aquino has shown you this video, but it just demonstrates that sort of sweeping motion across the eye. It's important to keep the eye well lubricated. And what you'll see here is that the eye is actually, the probe is actually being rotated as you go across the eye. So you're maintaining that perpendicular to the sclera, as well as rotating the probe as you go across the eye. So you can see here that it's quite a nice, smooth motion that you make with the probe gliding over the sclera. Now, in terms of my tips for success, so we've had an excellent presentation from Dr. Aquino in terms of anesthesia. If it's being done in the operating theater, then I use a subtenons block with 2% lignocaine. It's shorter acting, so the recovery of function of the eye is quicker. I do tell patients that they'll experience double vision through that day, but it should usually recover by the next morning when they wake up. I have done the procedure in the office, and in that situation, I have my compounding pharmacy make up some gel. So I have a gel that combines 5% lignocaine, some bupivacaine 0.5%, and I have added some adrenaline to that mixture as well. And I find the adrenaline is quite helpful because it vasoconstricts the blood vessels. So I apply the gel every 10 minutes for half an hour, and I find that that's quite tolerable to the patients. I do tape the eye shut during the procedure, and I use a Lieberman speculum to keep the eye open. Although sometimes with a small eye, it is better to do the procedure without a speculum. I do use a squint hook to help direct the eye, and sometimes a cotton bud can also be used as well if you haven't got a subtenon block. So here's a close-up of the probe. You can see here that there is a notch on the probe, and that's the side that sits adjacent to the limbus, and this flat end of the probe sits up against the eyelid. Now, one of the problems that I find is that it's not easy to visualize that notch because you've got safety glasses on while you're doing the procedure, and so you're trying to ensure the smooth motion of the probe across the sclera while keeping the probe perpendicular to the limbus and making sure that that notch is adjacent to the limbus all the time. So what I do is I get some MicroPulse tape and stick it over the probe in this area here, and then I use a marker pen to mark a line to indicate where the notch is. So you can see here that I've marked in green where the notch is. So that's really helpful in terms of knowing where the notch is at all times. So that's one thing that I would recommend that people do. That way you ensure that you know where that notch is at all times. So for me personally, I find that it is difficult to hold the probe perpendicular to the limbus and sweep across when I try to treat a whole hemisphere, and so I treat one quadrant at a time. So I use a power setting of 2000 milliwatts, and I apply that to each quadrant for 40 seconds. I do 5 sweeps across the quadrant, and what that means is that each quadrant takes about 8 seconds to sweep across. And so that gives you a bit of an idea about how fast the motion needs to be to get from one side of the quadrant to the other side of the quadrant. And so it's about 8 seconds to get from one side of the quadrant to the other, and I do that 5 times. Now, I find that lots of gel is very helpful. And what it does, it provides a good coupling so that we can deliver the laser energy from the end of the probe to the tissues where they need to go. Now, before I finish, I'll just share those few cases that I told you about that I started off with. So my first case, the pseudofoliated glaucoma case, she's done very well. Her pressure was 21 and has been sustained at that level out to 1 year of follow-up. The 54-year-old male with the multiple retinal detachments has done well as well. His pressure was 14, and we were able to get him off acetazolamide. He required a retreatment after 2 years, which I did about 6 months ago, and he's doing well once again. His pressure has been 12 without acetazolamide, but he's on drops. I've had a colleague recently who's done an 18-month-old baby with Sturgeweber, had a pressure of 28 and has had MicroPulse TLT. Pressure at 3 months is 21. And this is not a bad outcome because it does delay incisional surgery as long as possible. Another case of a 58-year-old male with open-angle glaucoma, pressure of 23 on maximal medical therapy, unwilling to have a trabeculectomy because his sister had a very bad outcome from having the same procedure. So I offered him MicroPulse TLT, and he's done very well. His pressure is 14 and he's off all medications at 1 year of follow-up. So in summary, there is a learning curve to this procedure. We do often choose our advanced or difficult cases to start with, which is okay. I do find it takes a little while to get used to maneuvering that probe. I am now starting to use it earlier in my treatment paradigm now, and overall, it's just another good tool to have in our glaucoma management armory. So with that, I wish you every success with the technology. Thank you very much.
Thank you, Iresh. Well, very useful. So especially the procedures in detail is very helpful for us. Thank you very much. So let's move on to the next presentations. So Victor, please.
Yeah, Thank you, Professor, for introducing me. And I also like to thank Iridex for this kind invitation for me to speak today. I think you have heard two great speakers, Dr. Cecilia, who has lots of experience working on this. And in many ways, more than one, she's been the one teaching me how to do MicroPulse when I was a resident. So you heard how the technology works and how her posts are with making it work. You have heard also how Professor Makoto has shared his experience with refractory glaucoma in the Japanese cohort. And you have heard Dr. Patel in selecting, the importance of selecting your first cases to do for MicroPulses. And he has shared his personal experience, how important it is to use a coupling agent, how to laser quadrants by quadrants. I think these are very important in that improving the outcomes for MicroPulse. So I thought that I would like to share something interesting. I would like to share cases in which I thought MicroPulse would be really useful and interesting. Many times it's been used as a form of a rescue therapy to get me out of tight situations. And for the past couple of months with COVID, I have been doing many more MicroPulse TLT compared to incisional surgeries, and I'll explain why so. I have no financial disclosures directly related to the content. I'd like to start with case number one. You could see that this is a 73-year-old Malay lady who came in just 2 weeks ago, three weeks ago to my clinic with an acute angle closure episode. You will see that the pressure was 65. She was squeezing a lot of her eye, but anyway, pressures were high, angles were narrow. You can see over here, the cornea is not clear. With some medical therapy, we are able to drop the pressure to 32, half of that, but yet the cornea still refused to clear up. And to add to the difficulty, she has advanced Alzheimer's, dementia, and is extremely combative. We could hardly come close to her. She has mood swings, and it is very difficult to do anything. You understand that it is even hard to put her at the slit lamp to examine her. And naturally speaking, without the ability to do a iridotomy, I would think a next best course of action is to do a phaco for her in the theater under GA. But she has recurrent cardiac failure, and when she first came with the COVID situation, we really have no high dependency bed. The anesthetist refused to put her under general anesthesia. And so I was thinking, what can I do to help reduce the pressure and break the attack safely, you know, without her. I mean, she can still move slightly, we can still control her movements, not a big issue. And I thought MicroPulse might be a good option over here. After all, you don't need much accuracy, you don't need much precision. The patient can be moving, but we could do with MicroPulse. And that's what I did. I performed MicroPulse, and on day one, pressure dropped to 12. She's still on 3 medications, and finally, in month, that's week 3, I beg your pardon, week 3, the IOP is 28 millimeters mercury. The cornea is clearer. I went on to do phacoemulsification for her, and the pressure is now back to normal. This is case number 2. Unfortunately, this poor gentleman had developed neovascular glaucoma with high pressures shortly after cataract surgery from another center. It was referred to me. You could see that there is florid new blood vessels on the iris. Intravitreal anti-VEGF was given with retinal laser given to the eyes with the help of my retinal colleague. The pressure did come down to 38 millimeters mercury with maximum medical therapy. And I did a combined MicroPulse laser to try to keep the pressure lower than 38 prior to definitive IOP control. And I've given him injection of anti-VEGF on the table as well. The pressure on day 1, you could see the pressure has dropped to 20 millimeters mercury on 3 meds, and subsequently 24 millimeters mercury on 3 meds. And even though the pressure is starting to creep up, at least the inflammation is settling down. The anti-VEGF was given time to work for the new vessels to regress, and then we went for an uneventful tube surgery. So this is how MicroPulse has helped me to increase the safety of my tube surgery, as well as make it easier because the cornea is clearer, and lower risk of hyphema because the time that I bought with the MicroPulse, it allowed the anti-VEGF to work quite well. And this is yet another difficult situation. This is a young 21-year-old lady who had contact lens associated infection, culture proven to be acanthamoeba. You could see that by the time the treatment has set in, the cornea has scarred up tremendously, giving her a very ugly look. So cosmesis is a big issue for her. But more importantly, the pressure is high, and the pressure was 35 on maximum medical therapy. The patient clearly required a tube surgery, but we couldn't do a lot of invasive surgeries during this procedure. The patient herself is also not keen for any invasive procedure during this period of time. And I thought, why not give MicroPulse laser another try? And this is post-op week 2, pressure of 17 on 3 meds. That's about half the pressure compared to pre-operatively. And at 2 months later, pressure is 20 millimeters mercury on 3 meds. And then subsequently, the patient underwent successful tube surgery and keratoplasty, as you can see over here. The case number 4 didn't happen during COVID. It is a patient that I managed 3 to 4 years ago. This is a patient that is 86 years old, elderly patient, and has pseudoexfoliation syndrome, as you can see over here in the picture. And he has advanced cataract in that eye. Now the pressure is 16 and is on 3 medications. Now, understandably, the patient is old, and the family who came with him felt that, we wanted the cataract surgery done, but we don't want anything very invasive for the glaucoma. He mentioned to me, "Doc, I do not like my eye drops. I keep forgetting them. I get red eyes. Could you do something about it?" Now, if you were to do just cataract surgery, that might reduce the pressure slightly, lower chance of getting him off the medication. And so I thought, shall we do a combined phaco with MicroPulse TLT? And this is the short-term results, post-op month 2, pressure of 13 and on 1 medicine. Unfortunately, I couldn't follow up the patient as the COVID hit us, and we couldn't get the patient back for his follow-up yet. But at least at month 2, the pressure is 13 and it's on 1 medicine, and the patient is pretty happy. I would like to now share a video of how we perform the laser. You have seen lasers videos by Dr. Patel and Dr. Cecilia. This is the Cycle G6 machine, and that's my settings. They are usually used. You see here, I had performed femtosecond laser pre-treatment to the cataract for one of my patients prior to the MicroPulse. And after that, with the MicroPulse done, I went on to perform a cataract surgery for him. The next 2 cases are rather interesting, which I thought we'll share in this platform as well. It's how MicroPulse has helped me to act as a rescue laser to reduce the pressure safely as well as non-invasively. And this is a young patient with an acute painful eye, and he has very bad eczema and is on lots of systemic steroids as well as topical steroids. He had cataract surgery when he was young, and from another center, and perhaps there might be some complicated anterior segment surgery, but you can see over here that there's a lot of lens material left behind the between the lens and the posterior capsule. He presented with a pressure of 52 and on maximum medical therapy, and really we were quite desperate, and he's on oral Diamox as well. We decided that MicroPulse could be useful as a rescue therapy. We performed that on day 1, pressure came down to 9. He was much happier, cornea is clearer. We are able to then safely perform ACA washout and removal of lens material. At 2 weeks post-op, just to prove a point that the laser doesn't induce too much unnecessary inflammation, the UBM was done, and you can see that there's no suprachoroidal effusion of fluid. And on day 21, pressure came down to 16, and his current and there's no intraocular pressure lowering medication. Case number 6 is even more uncommon. This is an elderly patient of one of my colleagues with a history of angle recession from badminton shuttlecock injury, and is a known patient with angle recession but no medications. He had cataract surgery done and subsequently developed posterior capsule opacification. You can see that there is the opacification there, and underwent a YAG laser capsulotomy. Not impossible, but uncommon. The pressure shot up to 64. There were cells in the AC and fibrin in the anterior chamber and flare as well. Once again, it's on maximum medical therapy, even on oral diamox, but the pressure is resistant to this medical therapy. And after consultation, we decided to give MicroPulse a try. And similar to case number 5, you could see that day 1, and it's just overnight, the pressure lowering effect of MicroPulse is quite potent. It comes down to 12, and day 7 is 14, and subsequently 3 months later, the pressure of 21 millimeters mercury without medication. The patient is a happy patient. These are my settings. I think I wouldn't hover around this too much. And Dr. Patel and Dr. Cecile has already gone through this quite a few times. The mechanisms are also explained by Dr. Cecilia. There's increase or enhanced reverse scleral outflow. Certainly we felt that was the case. There is also the possibility of ciliary body, ciliary muscle contraction or shortening that increases the trabecular meshwork outflow as well. In short, I hope that the series of cases that I've shown has showed the versatility of MicroPulse TLT as an effective, fast onset and safe intraocular pressure lowering procedure, at least as a temporizing measure. It can be combined with other procedures. I have seen it being, I've done it combined with cataract surgery or intravitreal injection of anti-VEGFs. And this could be a fast and a suitable procedure during COVID-19, especially when there is shortage of anesthetists, shortage of high dependency beds, and the reluctance to perform general anesthesia for our patients. Thank you very much.
Thank you, Victor. Thank you very much for presenting many refractory cases. So let's move on to the last presentation. So Dr. Lee, so please start.
So I think most of the technical aspects have been covered very comprehensively by our earlier speakers. So what I would like to talk about is focusing on when a single treatment of TLT does not go into the direction that we want, does not achieve the target pressure that we want, what we should do and how we should retreat if we decide to retreat or not at all. So I would like to share a particular case. This is a gentleman, 55-year-old Mr. X, who had advanced silicone oil-induced glaucoma. He had multiple left eye surgeries, including an early retinal detachment repair with silicone oil in situ back in 2014. He later had the oil removed in 2015 and had a subsequent phacoemulsification done the month later. That's when the pressure started to increase, and he had SLT done in May 2016. He received a second episode of silicone oil removal back in July 2016 for persistent high pressure and hope to clear away any residual silicone oil that may be in situ. And lastly, he had an anterior chamber washout done in March 2017, whereby he had pressures up to 40 millimeters mercury. So he had multiple surgeries done before he was referred to see me for the glaucoma management. So when he came to see me on presentation, he already had pale disc. The intraocular lens was in situ. I was able to see emulsified silicone oil, which is expected because even though we do silicone oil removal, a number does result in the anterior chamber. And at the back of his retina, he had 360 degrees barrier laser done, but it was a flat retina. And the presenting VA was quite poor, only around 0.08. And at that time, the pressure had gone down slightly at 24 on 4 types of anti-glaucoma medications. But given the severity of his case, we know that 24 is quite far off from his target pressure. So this was his visual field showing very, very dense inferior defects already when he came to see us. So the challenge that we encountered for this case was that this was a relatively young patient. He works as a university professor, so his vision is quite important to him, despite it being not so good to begin with. He had high myop to begin with, to make matters worse. So he had over 10 diopters of myopia before. He has gone through multiple surgeries, presenting with a pale disc, failed SLT, and overall he would be a candidate that would be quite a high risk if we were to do any incisional surgery. So high risk of having wipeouts, subsequent hypotonies because of post-vitrectomy, as also because of his high myopia, and scarring tendency because he's still relatively young with a good metabolism. So these were the downsides of choosing to do a conventional surgery. So at that juncture, we discussed with him about MicroPulse. And I remember this back in 2017, the technology had just been introduced in Hong Kong. So this was one of the earlier cases that we did. So we followed the standard protocol of the power, the duty cycle, treating 360 degrees, avoiding the 3 and 9 o'clock regions. And at that juncture, we used a total treatment of 120 seconds, so around 60 seconds per hemisphere, over around 5 or 6 passes per hemisphere. So after the initial treatment, his pressure did come down to around low teens, but gradually over the next 1 to 2 months, it kind of climbed back up to around the 17, 18 range. Wasn't at all that bad, but given his the severity of his glaucoma, we were hoping at least somewhere less than 16, if not in the low teens range. So at 2 months, we were faced with the decision of whether or not to proceed with an incisional surgery, such as a trabeculectomy or a glaucoma drainage device, versus a traditional G-probe TSCP, or to repeat the MicroPulse TLT. So after discussion with him, he was quite eager to repeat the TLT because the overall experience postoperatively was quite good. I mean, he used a few weeks of steroids, and he was basically able to resume most of his duties. So at that juncture, we gave a second course of treatment. Now, during this second treatment, we followed the same protocol, but we increased the treatment duration to a little bit higher, using around 80 seconds per hemisphere for a total of 160 seconds, also over 5 or 6 passes per hemisphere. After the second treatment, his pressure was able to come down from 17 to 18 millimeters of mercury down to the mid-teens range for almost 2.5 years. And just recently, when I last saw him a few months ago, his pressure started to gradually climb back up to around the 17, 18 range. So near the pressure of his second treatment. So even after the second treatment, he has never gone back up to beyond 21, so always in around the mid-teens range. But since for the past 2 clinical visits, his pressure came back up to around 18, we discussed with him for the third treatment in hope for the additive effect of further increasing the uveoscleral outflow. So he received his third treatment just last month, and his pressure has been quite well gone down to 12 millimeters of mercury since, and hopefully with the third treatment we would be able to see an extended benefit, just like after second treatment. Hopefully it will last him for another few years. For the third treatment, having gained more exposure using this laser, we were able to get a better sense of the titration in terms of the time used. So this time we used 180 seconds, so a little bit more than his first and second treatment, for 90 seconds per quadrant, and again over 5 or 6 passes per quadrant, per hemisphere. And quite lucky for us as well as for the patient is that his clinical parameters were kept relatively stable during this period. So his OCT for retinal nerve fibrillary status was able to be maintained around 79 micrometers to around 77 in 2019. And his visual field index has not dropped too much, around 1% only from 2016 to 2019. Now, the number of eye drops that he has been on remains unchanged, so he's still on 4 types of anti-glaucoma eye drops, but in fixed combination. So it doesn't, it doesn't affect his lifestyle that much. He's just applying Ganfort as well as Imbrinza over his eyes, and his vision has been maintained at 0.1, but mind you that his baseline was only 0.08 to begin with at 3 years. And I'm not so sure that we would be able to keep this vision had he had done a trap or a glaucoma drainage device. So having gone through a number, 5 or 6 previous surgeries, and still being able to maintain a vision after 3 years, I mean, the patient was relatively quite satisfied. So in just a summary of my own encounters with TLT is that some of the pros of this technology is that we're able to achieve IOP reductions of somewhere between the 30s and 50s range. It is applicable for a broad subtype of glaucomas, as all of our speakers have mentioned. Most patients are able to take off their oral diamox, but it seems that the number of topical eye drops may not have significant reductions. Of course, being an extraocular surgery, there's no risk of infection, very minimal inflammation and subsequent downtime, and ideal for those who are unable to return for follow-ups, be it for geography or any other reasons. And the vision relatively is unaffected, and being the extraocular nature of the procedure, there's less cataract, less wipeout risk, less hypotony, and suprachoroidal hemorrhage risk. And of course, the laser itself is scarless and it's repeatable. Some of the minor cons for the laser is that the IOP reduction is, of course, not as much as a trap or a tube, which is expected from any minimally invasive procedure. As mentioned, the number of topical anti-glaucoma eye drops may not have significant reductions, and I think this is also important to discuss with the patient so that they're set in terms of the mindset that this is probably not a medication reduction type of surgery. And some patients we noticed earlier on during our treatments is that they tend to have pupil dilatations, which do respond to a 1 or 2 weeks course of pilocarpine, and they tend to have a higher tendency of dry eyes. But we later learned that the company is modifying the probe so that it would have a better fit to eyes that are a bit smaller, which is particularly useful when we treat patients of Asian ethnicity where the eyes are a bit smaller, and so having a smaller probe may avoid these potential downsides. And a number of patients do need a second treatment, but it seems that so far the second or even third treatments do seem to reestablish the IOP reductions. And it seems that those who start off with a higher pressure seem to benefit from greater reduction, which is similar to SLT. And it seems that it doesn't really get patients down to the very, very low teens range for a long time. They seem to kind of regress back to the mid-teens range. So when we're selecting patients, when keeping in mind the target pressure, for those who really need very, very low teen IOP, probably we have to, discuss with them and consider, given this nature of the technology. And that's my talk. Thank you.
Thank you for a nice presentation, Jackie.
Thank you, Professor.
So please give us a few minutes to answer many questions. So one of the questions is, what are your parameters settings for retreatment? So Jackie, can you answer?
Yes. The parameters of retreatment, I guess, would be similar to the standard protocol. I mean, the only parameter that we can really modify is the duration of treatment. So if you, I guess it really depends on the case. If it is within a short duration of treatment, for example, within the first 3 months, then probably it's a good idea to increase a little bit in the time compared to your first treatment, given that during the first treatment, you're not treating beyond 100 seconds per hemisphere. But let's say in the third treatment that we did for this patient, where the treatment span was already more than 2.5 years, then we know that it is not really an inadequacy of treatment, but it's just over time that the laser does lose its effect. So when you're treating or retreating over an extended period of time where the patient had a good response in your initial protocol, then I think it's reasonable to keep the same protocol, maybe just adjust the treatment duration by a little bit more, just to kind of reestablish the existing flow. So it really depends on when you're treating.
Okay. So another question about the procedures. So how often can you perform the procedure, and what's the ideal interval in between treatment? So somebody can answer this question?
I'll
Cecilia?
answer the question.
Yeah, thank you.
In considering retreatment, you wait 6 weeks before deciding to treat the patient, and that will give the patient time to recover from the inflammation or the pupil dilation or any other problems encountered after the first treatment. And regarding the parameters for a repeat treatment, with the standard protocol that we are using, we use a 100 seconds duration of treatment when we retreat. When we did it many years ago, we'll use the standard protocol.
Thank you. Any other opinions? Okay, so next question is, so what factors determine the duration of laser in the setting? Anybody answer? But of course, it depends on the individuals.
That's right. But I feel that. Oh, okay, Cecile, please.
Oh, Victor, please.
Go ahead, Victor.
Victor, go ahead.
Go ahead.
I
Sorry
think
for interrupting.
It depends. It depends on how comfortable you are with the MicroPulse laser. If you are a first-time user versus an experienced user, because you would need to have, you would probably go on to develop some form of normative pathway and determining which settings works well for you and for which condition. I would recommend that for the first few cases that you do, go with the standard settings or even lower settings and see how the response is to that particular laser. And if there is good effect on it and it lasts long, you probably want to repeat it again if there's a need to. But if the outcome is not as good, you may want to change your settings and increase the settings or try other forms of procedure apart from MicroPulse TLT. So there's no, to answer that, there's no fixed answer to that, but I would say to be as safe as possible, go with the most conservative duration as well as power settings when you first start out.
So any comments? Okay. So we need to rush more, many questions. So as regarding to the retreatment, so what about the pain sensation for the patient when we do retreat? Do you have any options for the retreatments for the pain sensation? Same with the first one?
Maybe I can answer that.
Yeah.
I think as Dr. Cecilia has very importantly highlighted, is that we tend to wait until the inflammation subsides before we retreat, and I think that would in a way control the pain. So if we're retreating within I guess less than 8 weeks, then first of all we don't know whether or not the the relatively high pressure is maybe due to steroid effect or due to the residual inflammation. So once the inflammation comes down and we retreat, the pain sensation will not at least be heightened. But I don't think retreatment will increase the pain sensation for the patient. For example, in the case that we have retreated 3 times, during the second or third intervals, he didn't repeat a particular, he didn't volunteer a particularly higher or lower pain threshold than the first treatment. So I think you can just proceed as you would the first treatment. But I guess there's always the option of doing it under general anesthesia or MAC if the patient is very, very pain sensitive. And I guess that's also particularly useful for very advanced cases where you may not want to inject them with a retrobulbar with the risk of having induced any retinal occlusions or wipeout from the regional injection itself.
Okay, so thank you very much. So
to add on to that, Prof, to add on to that, I think the patient's first experience is very important. If they has a good experience and a pain-free experience for the first time you do the MicroPulse, they are more likely to say yes when you want to, repeat the MicroPulse again. I have a lot of patients who had MicroPulse done, and it's such a painful experience to them. When you re-offer them again the treatment, I tell you the answer is a flat no.
Yes, thank you. So this is one of the fundamental questions. What's the safety profile and long-term complications of this procedure? Actually, this is very safe compared to the G-probe. So, or do you have any comments about endothelial or?
Yeah, I agree that the safety profile is very good. I've had no cases of hypotony. Very occasionally, I've had a bit of corneal edema and corneal endothelial changes, I should say. But those are transient and all have resolved. On the point of inflammation, I find that there is very little inflammation on day 1 in these treated eyes. I have done a very small number of uveitics, and there is some increase in the inflammation following the procedure, but it hasn't been overbearing. And generally, I do increase the topical steroids after the treatment for those sort of patients.
Yes, I agree. Thank you. So
may I add, Prof?
Yes, Cecilia, please.
Comment about the complications and the safety profile. If I can just cite that the early years of our treatment using this therapy, and this was published in 2010. We treated, of course, a lot of eyes, 40 eyes, but with advanced and refractory cases. We didn't encounter any hypotony at all, and no phthisis. This is 16 months follow-up. And then we repeated, and this time we did a randomized exploratory trial. And similarly, we did not encounter for 18 months, we treated, we randomized. We did not encounter anyone with hypotony or phthisis bulbi in the MicroPulse treated group, in contrast to the continuous wave or the conventional treatment that we do with the continuous wave continuous wave DCP. So it's a very, very safe procedure, and based on, I think it's also based on the laser parameter that you will use. So, and depending also on your experience.
Thank you.
Thank you.
I also have no hypothesis. So, any comments? Okay.
Just want to add one final comment. It's also quite forgiving on the cornea as well. And we have done cases in pediatric glaucomas who have had grafts, corneal grafts, and the grafts remain quite clear even after the procedure. So again, if the cornea is also concerned, it's also quite a good choice for these patients.
Thank you. Okay, so there are many questions. Thank you very much for everyone. So it's time to close. Thank you very much for everyone. So around 260 attendees here. So this webinar, I'm very glad to have a chance to speak in such an audience. We really appreciate all speakers and all attendees. Thank you very much. I'll see you in the next meeting. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Everybody.